Welcome, everyone. This is another edition of the One Brooklyn Healthcare Black History panel discussion that I'm excited to introduce our moderator for today, Dr. Thomas, who is our One Brooklyn Health Ambulatory Care Chairperson at Brookdale Hospital. And today's topic is on racial disparities in our communities and what One Brooklyn Health is doing to actually bring to combat this issue. We have some great panelists here that you will be excited to hear from. And once again, I'd like to introduce Dr. Thomas, who is our chairperson for ambulatory care at Brookdale Hospital. Dr. Thomas?
Good morning, and thank you. I am very excited also to join this panel of wonderful executives who are at One Brooklyn Health. It is my honor to introduce Dr. Sandy Scott, who serves as the Executive Director for Brookdale Hospital, as well as Dr. Torian Easterling, who is recently joining us as the Vice President of Population and Community Health, and also our Chief Strategy and Innovation Officer. Good morning.
Good morning.
Good morning. So as we were introduced, we want to talk about health disparities, but I think it's critical for everyone to understand your background, your history, and what you bring to your role currently at One Brooklyn Health. So Dr. Scott, I would like to start with you. If you could just explain to us a little of your upbringing, your interest in medicine, and any issues that you may have experienced in medicine that you think have had an effect on African-American population.
Sure. So good morning, everyone. I'm originally from New Orleans, Louisiana. I was actually born in New Orleans, raised in Baton Rouge, and spent my formative years in Baton Rouge, Louisiana. So I have a lot of Southern culture during my upbringing. I decided to be a physician at the age of 6. And never changed my mind. Went to college at Louisiana State University, medical school at Baylor College of Medicine. At the time that I went to medical school, there was actually a movement there was a movement to have more people of African descent, or Blacks, African Americans, and Latinx people join Baylor. And so my class had the largest number of minorities ever in the history of the school. There were about 12 of us, and about 4 to 5 of us actually graduated on time. So I lost about 50% of the people of color that I started medical school with. I left Baylor in Houston, Texas, and did a residency in emergency medicine at Boston Medical Center. At the time when I was Boston City Hospital, completed my residency in Boston, and then came to Kings County, not too far from Brookdale Hospital, where I had my first job as an emergency physician. And then I continued to work in emergency medicine for over 20 years, serving as chief of emergency medicine at what is now Rutgers in Newark, New Jersey, and then chair of emergency medicine at Lincoln in the South Bronx. And then from Lincoln, I came to One Brooklyn Health, where I became the chair of emergency medicine for the system. And then about 1.5 years ago, I became the executive director here at Brookdale. So I'm extremely excited to be here, extremely excited to help to raise the quality of care for the people in the Brownsville community. So thank you for having me.
Thank you. Thank you for that great introduction. And Dr. Easterling, for a fair number of our viewers, I'm sure they may recognize you from some of the commercials that are during the COVID outbreak. If you could explain your background, your history, where you come from, and why you decided medicine was your choice as a career.
Sure. Well, good morning. It's a pleasure to be joining you both. Certainly a timely conversation, given, sort of the moment that we're in this country, and then also, the month that we're in, celebrating Black history, Black culture, and all the experiences that, make up this community. So just as a way of introduction, again, Torian Easterling, I am a family physician, public health physician, been practicing now for nearly 15 years. In this specialty, both in a clinical role, but also in an administrative role as well. I trained at Rutgers, New Jersey Medical School, where I actually first met Dr. Scott, formerly of the University of Medicine in New Jersey, and got my medical degree there before going on to Jamaica Hospital in Queens, where I trained in family medicine, and then going on to Sinai, or Icon School of Medicine at Sinai, where I completed a 2-year residency in preventive medicine, and also received my public health degree. What really shaped my journey into medicine, very similar to Dr. Scott, I knew at a very young age that I wanted to be a physician. And I credit my mother, Lucille Easterling, for really ushering me through. I grew up in Newark, New Jersey, and very similar to Brooklyn. When you think about the social economic conditions, the political conditions, I mean, we had a Black mayor. We had a city council that was predominantly folks of color, but there were a lot of conditions that I couldn't explain and understand why the conditions just didn't really support the community to really thrive. And my mother was really adamant, that her sons really need to just be focused and intentional about what they want to do, and really she supported all of our dreams. And so I really do credit her for shaping the way that I've been able to navigate my journey. She certainly wanted to be a physician. She did not go to medical school. She ended up getting a certificate in natural medicine, the art of natural medicine, from Drexel University in Philadelphia. And at a very young age, I had an opportunity to really just be in herbs and minerals, which is really important to our culture. I mean, really it starts, from Africa, and it had, came through the South, really being able to dig our hands in the dirt, understand things like golden seal and echinacea, all the things that we use in our community to keep us well. And things that I would say in a lot of ways have been shunned upon and given negative connotations about how we are able to take care of ourselves and really be intentional about wellness and not waiting for care, right, and within a medical institution. And so, again, I really appreciate, that upbringing, one, of just understanding how the art of therapy is really important for families. Just remember juicing, on a weekly basis, like cod liver oil. I'm sure everyone remembers cod liver oil.
Yes, not favorably.
No, not at all. But the other thing that's really important is in the intersection of it is just also, growing up in a time where there's this movement of Black people, this movement of Black empowerment, from the 70s to the 80s, there was a lot in our music, the Black Panther Party, although they were dwindling down, they still really had a stronghold in Newark and Chicago, in New York City. But you knew that folks were moving into the underground. But what we saw is that there was a movement into this Black empowerment stage, and I think it was really important, as in our upbringing, that we sort of really got to understand how important it is to see yourself as beautiful, as powerful, as vibrant in our community. And I think that also plays into why this work, the work that we do, being at One Brooklyn Health, a reinvestment strategy of what healthcare, of what wellness could look like for Central Brooklyn. And I think it's really a right moment.
Well, you've already started us off on a great foot. I think it sounds, of course, like a lot of commitment, a lot of concern about our community, Brownsville in particular, which we serve here in One Brooklyn Health. Dr. Scott, we talk a lot about the history of the African-American community not feeling fully embracing the medical community and the recommendations that we share. Can you explain to us why some of the issues that the African community has had with the medical profession, with the work that we try and accomplish?
Sure. So I think if you look back in America, right, and you think about the slaves' experience with medicine, right? So a slave on a plantation with a an acute illness because they're really, obviously the diet and conditions were not conducive to promoting wellness. But when a slave had a condition or an acute illness that prevented them from working, it was the master or the slave owner that called the physician, right? And so that the physician's relationship to the patient was very different from the doctor-patient relationship that we see today. And I think it's important to understand the history of medicine in America so that we can understand and contextualize the care that we're providing today. And it's the responsibility of the medical community to gain the trust of the communities that we serve, as opposed to it being the patient's responsibility to build trust with us. It's our responsibility to instill that trust in the patient, understanding where the doctor-patient relationship originated for people who are descendants of slaves and poor people in this country.
Right. And specifically, I know we often hear brought up issues around the Tuskegee syphilis study, as well as the Willowbrook hepatitis study. We know that these are instances where African Americans were essentially used to help promote, to help identify and study certain types of diseases. Do you feel that the ramifications of those studies still have impact on concern that our community has in embracing and fully engaging with the medical community? Dr. Easterling, do you have any issues on that?
Yeah, so absolutely. I mean, the short answer is yes. The impact, the vestige of medical experimentation, of withholding treatment from folks of color really have an impact today. But we don't have to go back to sort of the historical injustices within, the medical industrial complex. I mean, we're talking about things that are happening right now that are contemporary injustices that continue to lead to this further divide that Dr. Scott started to right now, right? In 2023, when we can look at inequities around maternal health and infant health care right here in New York City, we know that Black women are more than 8 times more likely to die than white women in childbirth, or even have pregnancy complications. In infant health, although we have seen a decline in rates over the last decade or two, we still see a persistent gap between Black infants versus white infants. And it's not to say that, the goal is to get where white infants are and sort of their ability to live to at least 1 year of age, but we understand that there is a baseline that all communities should at least be at. We certainly want everyone to be healthy. We want everyone to achieve their most optimal health. But the baseline for the Black community, for Hispanic and Latino community, is not where it should be. And these are things that I would say in medical school not made clear. Oftentimes what we always heard was health disparities. And I think it's really important to sort of anchor us in some of the definitions. When we talk about health disparities, we're only simply saying that there's a difference. There's a difference in the rate. There's a difference in the number of individuals of having a certain disease outcome compared to a comparison group. But that's not enough, because oftentimes what you're saying is that, well, those people are to blame for their poor health, for having higher rates of diabetes, for having higher rates of heart failure, higher rates of prostate cancer. When we know that when we know that these conditions started long before any of us have been alive, during enslavement, Reconstruction era, Jim Crow era, and you talked about Tuskegee. I mean, the path has been laid when we see these injustices happening. And it's largely because of the social economic conditions in which Black communities to endure throughout the centuries in this country. And I think it's really important that we cannot lose sight that we need to shift blame away from individuals and be able to talk about how institutions and policies have led to these inequities.
Yes, and I think you're reminding me of the paradigm that started with blaming the patient, right? And so within medicine, there was a whole movement to describe Black people as different somehow. And somehow our differences, right, is what contribute to those disparities, right? So for example, things like saying that Black people didn't endure pain, or that Black people had smaller brains, or Black people had a different level of immunity. Those kinds of beliefs were entrenched in medical education. So that led to withholding of treatment, right? Withholding of treatment because somehow this group of people were different and they wouldn't respond to treatment anyway. Or maybe these people are different, Black people are different, and they don't want treatment, right? Oh, they wouldn't accept the treatment even if we gave it to them. And so those beliefs that were entrenched in medical education also help to prevent the advancement of health for Black people. And I think that's, to your point, it's the structural racism in medicine that we, the institution, must work very hard to undo.
So understanding, as Dr. Easterling also brings up, that it's not only a historical issue, but that it persists today. And I think we saw some of that also with the COVID pandemic and the placement of testing sites throughout New York City. And of course, those with the predominance of African Americans were some of the latest to get those testing sites. So I think we all have to remain vigilant, and it remains a serious concern. So as part of that, we have Brookdale, we have our other sister sites in One Brooklyn Health. How do we address that as a health system? How have we started to try and engage our community so that they understand that we're working with them? Dr. Scott, if you would like to address that.
Sure. So I think if there are multiple levels that we're addressing the structural racism within our institution. So from a clinical perspective, we've started to look at certain algorithms, right? So there are certain, when I say algorithms, I mean ways that we diagnose disease. So if you look at renal failure or kidney failure, for example, there are certain tests that we use, for example, when someone might qualify for a kidney transplant. And inherent in those algorithms were kind of race coefficients or race adjustments. And those race adjustments prevented Black people from being eligible for kidney transplants compared to white people, for example. So at One Brooklyn Health, we changed that algorithm so that we remove that race coefficient, and we're taking a look at those patients who might have qualified for a kidney transplant had we used the algorithm that we're using today that removed race. So looking at specifically how we diagnose and treat and removing those racial factors that delay treatment, to things like just looking at the process of how we deliver healthcare. And I think the most important thing that we're doing is engaging the community in that work. How does the community want to access healthcare? For example, do we have more opportunity to provide care via telemedicine? And so just looking at everything from clinical processes to how we decide who is eligible for certain treatments to remove those barriers to access to care.
Dr. Easterling, can you also respond? Thank you.
Yeah, absolutely. I mean, I think that this is powerfully important, and I think, folks who are, who have a chance to tap in and sort of link with us and sort of watching this recording, I think the ways in which we're doing it is just looking at this screen. And although Sharon, you cannot see Sharon lead, understand that leadership represents the community that we're serving. I mean, you look across the Power 5 systems, you look across the safety net systems, the makeup of leadership does not reflect the community that it serves. And so I just wanted to start simply there and just honor what is happening here at One Brooklyn, to have a Dr. Scott in leadership at Brookdale, to have a Miss Lorraine Brown as leadership for the entire system. And we know that, just having a face as leadership is not enough. And so to also have Dr. Scott here naming structural racism, and we know that commitment not only starts and stops with Dr. Scott, but it is across our leadership. And I think that's also important, that we can both represent and look like the community that we serve, but also we can understand the root cause of why these inequities are, and be bold enough and courageous enough to talk about it and to lead on the actions. I think that that is powerfully important, because what that then allows us to do is to also understand the harms that have previously happened and how they're perpetuating today. And I think that who have that level of emotional intelligence will be able to reach across the aisle and say to our community, we have made mistakes. We know those mistakes have led to irreversible harm in a lot of ways. It has caused death across our city. And we need to move forward together, right? And I think that that's just being able to connect with someone at the heart level, at a human level, and say that we really need to come together and think about how we're working to improve everyone's health, but specifically those who have been harmed the most on so many different levels. And so I think that that's really important, and is also the reason why I joined the system. And then I think that the other work that has been powerfully important here across the system is, you've already heard about the clinical algorithms to end race-based clinical care. But there's also work that we're looking at specific inequities that we outcomes. I've already named maternal health outcomes that are happening across the city in the work for One Brooklyn Health, to not only specifically think about care, but also our partnership in the communities. And so, led by Dr. Cyrus McCullough, our chair of obstetrics and gynecology, I mean, really important to think about not only how we're providing care in our hospitals, but working with doulas and midwives and organizations across Central Brooklyn to bring better access into the home, right? Because we know that 40% of what we do matters, but really it's what happens in our community, in the homes, at work, where people are worshiping. That's where we really need to make those connections. And I think that's been one area that I think has been really important. But then I think the other thing that's also important is that we don't just think about health, right? Health care. We also think about the social determinants of health. We think about housing. We think about the safety. One of the ways in which One Brooklyn Health has really sort of led in safety is having a violence prevention work and working with New York City Cure Violence Program. I mean, this has been powerfully important for a health system, an anchor institution, to really make sure that they understand that their responsibility is not within the four walls of the institution, but also within the entire community.
Thank you for that, Dr. Easterling. I think the commitment to a diverse workforce is very important, very important. And so one of the things that I'm very dogged about is making sure that we have a very diverse workforce so that we can have a new perspective and an innovative way of thinking about how we deliver care, right? If you have a homogenous group, you're going to get homogenous ideas. And so by having a diverse workforce and collaborating with the community, right, bringing the need to be in the community, as Dr. Easterling has said, but also welcoming the community into our institution to help us transform the way that we deliver healthcare.
Absolutely. I think the community has to feel comfortable with their healthcare providers. They have to feel confident that we will always have their interests at heart. And I think, again, as you've mentioned, that having people in positions where they can support and encourage good outcomes, good interface with our community is absolutely critical. And ensuring that any staff that we bring on into One Brooklyn Health wants to work here, wants to work with this population, and is really concerned about improving their care. So we've talked a little about, how we are encouraging our staff. We have a broader range. We have people who are truly committed to the community. What else is One Brooklyn Health doing to help ensure that the community care, community health is improving? We know that some of our greatest challenges are cancer rates are highest also in the Brownsville community as compared with the rest of New York City, as well as diabetes. Do we have any special initiatives that we've started to help address those concerns?
So I'll speak a little bit about our Diabetes Center of Excellence, which is located at Pierre Toussaint. And what a Center of Excellence does is bring together not only the medical care, but the psychosocial support as well. So we have community health workers, we have technology. So our diabetes center is actually providing technology so that patients are able to monitor their blood sugar, their blood pressure, if that's indicated, their weight, right? So using technology to help promote and advance the health of those patients who are suffering with diabetes. So that's an example of where we've brought all of the resources, not just the physician, but all of the other social resources and community resources to help patients with diabetes thrive. Dr. Easterling?
Yeah, I think we constantly have to think about, you know, these health inequities and the outcomes, right? So one of the reasons, you know, sort of being in this role for this system is really to sort of think about those root causes of why we see the health inequities, you know, in the first place. And I think part of it is moving upstream and really sort of thinking about, well, what are the levers? What are the drivers of why we see these inequities? Certainly, we want to continue to bring resources into our community, linking individuals to care, making sure that they're getting the best health outcomes, and also leveraging the right messengers, right? You know, from faith-based institutions to community-based organizations, and really working with them. But as the Senior Vice President for Population and Community Health, it's also my responsibility to sort of think about, well, what are those policies? What are the data points? What are those resources that we should be leveraging, that we can really think about the entire community? We know in Central Brooklyn, there are over 1 million residents. And the scariest thing about being in New York City is that there's a tale of two cities, that you can live in a zip code like 11212, which is smack dab in Brownsville, and only 4 miles away, there's a higher life expectancy. And so 11-year age gap and someone being able to live their fullest life in, say, you know, somewhere in the Flatiron District or Lower East Side compared to being in Brownsville.
Yeah.
And so we really have to just talk about, like, why does that even happen? What are the conditions that make it so that someone can live so close to me and I can be 6 stops away, likely to die at an early age? Premature mortality is dying before the age of 65, and for mortality is dying before the age of 1. And we know that in Brownsville and Bedford-Stuyvesant and Bushwick and East New York, all the neighborhoods that we service, we have a lower life expectancy for our elders, and we have a lower life expectancy for our babies. And that just shouldn't happen. And so while, yes, we focus on trying to drive down our diabetes rates, which is top 5 leading causes of death and across the world, while we try to drive down our cardiovascular rates, which is also a top leading cause of death, COVID-19 is a top leading cause of death. Cancer, as you said, top leading cause of death. But we also understand, and how we started this conversation, because we understand structural racism at the root of all of it has led to these poor health outcomes. And so where have we seen how structural racism has played its part in leading to these health inequities? Well, housing is certainly one of them. You know, when you talk about the early 1900s and how redlining policies has led to the disinvestment in certain neighborhoods, which led to the disinvestment in certain healthcare institutions like a One Brooklyn Health System, well, then what do we need to do to ensure that a reinvestment strategy is going to work? Well, certainly in 2016, the $1.4 billion, the Kings County Transformation Grant that went into this system to make sure that we improve the aesthetics, to make sure that we have capital investments, to make sure that we have the type of programming that Dr. Scott mentioned, is certainly important. Well, then what is the power and the access for someone to access healthcare? Well, that's health insurance. And we know that we primarily service our Medicaid and Medicare population. And we certainly know that we do not get paid nearly as much as commercial payers in providing the same service. That means that someone is accessing their primary care, accessing their surgery, being able to deliver their child at this hospital. This hospital receives a lower. And so we're actively working with other states in that system to ensure that we're receiving a higher reimbursement rate. These are policies that have been in existence long before any of us has been in leadership. And so while we have to do our hardest and be diligent in making sure we provide the best care, we certainly have to advocate. We have to advocate for the value for individuals to make sure that they're receiving all of the resources that are necessary to improve their best health. And that's why I think it's so powerful that you have leaders who are not just concerned about our ability to provide the care, but we're on the front line. Yes, we're advocating for our staff, and we serve 1190. We have our staff who are represented by 1199 and NISNA, but we're also thinking about, well, what are all the resources that we need to bring to our neighborhoods to ensure the best care possible.
I was just thinking, it's everything from, you say, what is One Brooklyn Health doing, right? It's from, being out in the community and in Albany and advocating for policy change that Dr. Easterling was describing, but also day to day, actually, we're delivering the care, right? So it's the whole continuum. It's like providing the care in a safe, equitable, efficient way, to actually being on the streets and demanding that there be a change in these policies that have perpetuated the inequities.
Right. Well, from a more ambulatory care end, I will state also that we have a fair number of healthcare sites within the communities staffed with extraordinary personnel and healthcare providers. And we say as our mantra, the healthcare measures in terms of improving our diabetes care, in terms of improving our preventive measures so that cancer rates will decrease. If cancer is found, it will be found at an earlier stage and at a treatable stage. So these are a lot of the initiatives that we are working strongly for. And again, I think you'll come to our sites and see people who look like you and understand a lot of the issues that you experience. And you'll hopefully feel a lot more comfortable and engaged in your care by doing so. Are there any additional comments? Yes, Dr. Easterling.
I realized that Dr. Scott and I had a chance to introduce ourselves and talk a little bit about the roles that we have here, but you have not. And I think it really is important and powerful that you also share a bit about yourself and the work that you do here.
Okay, I will. Thank you. I am the medical director of ambulatory care at Brookdale Hospital, where we have 5 ambulatory care sites, as I've mentioned, all approximately 1 to 2 miles away from the hospital. So we have preventive primary care work that is being done at those sites, both adult medicine and pediatrics. We also have a good number of specialty providers that are coming out to those sites, but most of our radiologic imaging studies are done here at the hospital. But again, as we understand the issues and the problems of getting to the site, we're working toward having a lot of those studies done at the site. So it's constantly growing, constantly learning and understanding what are the barriers that are preventing our patients from getting optimal care, and always looking to address. And I have to say, current administration has been extraordinary in assisting us with the staffing, with the support to really move those issues forward. I also serve as an assistant program director in internal medicine. This has been my first year in that role, and I am excited to say that as part of the interviewing process for our incoming medical residents, it is extraordinarily important for me to understand that they care about our community, that they are vested in making a difference, and that they're not just here to learn on some of the sickest patients in the city and then take that information, that expertise elsewhere. So I'm wonderful to have had that opportunity also. Thank you for letting me share that. Any comments as we bring this wonderful session to a close? Any comments that you want to say about what we're doing at One Brooklyn Health, where you hope that we're going to be able to really make a dent on improving, that our community is going through?
Well, I'll say that I really want the community to be a part of the transformation that's happening at One Brooklyn Health. We cannot do this by ourselves. We need you. We care for you, and we look forward to working with the community in the future to continue to grow and transform. So thank you for having me.
Thank you. Thank you, Dr. Scott. Dr. Easterling, any last comments? Dr. Easterling, can you hear me? Oh, any last comments?
Yeah, I was just waiting for the train to go by. Yes, and I totally agree with Dr. Scott that our ability to be available, accessible, to really just work with our community and defining what the health outcomes that are most important in the community, to define the ways in which we're going to address them together, and not just come up with those solutions on our own, and really move the needle forward. And we certainly have been doing that here at One Brooklyn Health, and we want to continue to do that. I think that there has been a lot of work that has been done to change the narrative about this system, to show the ways in which we care about our community, and we want to continue to move that forward. And so I certainly look forward to our partnership with all of you, not just on this call, but those of you who are listening, and tell a friend to tell a friend, about the things that are happening here. Your voice matters. Your ability to pass the word on, to say, One Brooklyn Health is making a transformation, and they are looking for you to be a part of it. And there are a number of different ways that we're connecting with community members, with organizations, to define what that change looks like. So, I'm excited, and I look forward to that partnership.
Thank you. Well, thank you both. I think for everyone listening to this webinar, you will agree with me that One Brooklyn Health is in excellent hands. We have wonderful leadership. We have caring and concerned leaders, and we look forward to working with you in the future. Thank you.
Thank you.
Okay, thank you so much for staying with us to watch the video. We have our CEO, Ms. Lorraine Brown, on the line, as well as Dr. Easterling. I'm going to ask Ms. Brown if you'd like to make statements. Can you please unmute yourself?
Well, thank you very much. And I listened to everyone, and I was excited to hear from my colleagues their enthusiasm and their commitment to One Brooklyn Health. I'd like to say this. There was a lot of emphasis on wanting to engage the community and helping us with our transformation. And for me, the community includes all of our staff. In addition to the folks who live in all of the neighborhoods, not just Brownsville, but Crown Heights, East New York, Prospect Heights, Bushwick, as was mentioned, of course, Bed-Stuy, not just the folks who live in those communities and for whom we hope that they'll choose to use our healthcare system, but our staff. Our staff are an important part of our community, and our staff must also believe what we believe, which is we can provide the best possible care in the most empathetic and sensitive way, and we can improve the health of our patients and the communities that we serve. But our staff have to really believe in our mission, and they also have to value our patients. And oftentimes, and I say this, and sometimes it's painful, it is not enough to just be, to have the leadership be people of color. It is absolutely critical that the staff, who are in most cases people of color, with exception of some of the sort of physician employees, who also need to be committed to doing away with the decades of mistreatment and disrespect and lack of responsiveness and support and caring. So that is critical within the context of our mission. I was also heartened to hear Dr. Thomas talk about the selection of our residency, new trainees in terms of our residency training programs. When I first got here 7 years ago, the very first thing I said to, at that point, the chair of medicine, who was also the program director at Interfaith, was, you got to change who you are recruiting to be the physicians of the future. They have to look like our patients. They have to care about our patients, and they have to be folks who want to stay in our communities. And we have a lot more to do in that regard, but we are making some inroads. I would also say that it's not an accident that you saw the 3 people on the screen. It has been my commitment from day one to make sure that leadership, as well as most senior leadership to department leadership, all across the continuum of our table of organization, that they be people of color, and if not people of color, people who are in the minority, but who believe in anti-racism and believe in Brooklyn. The other important issue that was raised was social determinants of health. And again, small things make a difference, and we need to be thinking about those issues that Dr. Easterling articulated as it relates to housing, employment, community wealth, and which is why some of you who've listened here, you may connect the dots to why we are making available certain parcels of our property for affordable housing. From my perspective, housing is health, and without one, you don't have the other. And that is why we are working very hard, and frankly, in some ways, spending a lot of energy, sometimes frustrating, with both the state and housing developers to create affordable housing on our campuses, because otherwise the creation of affordable housing is even more difficult in a city like New York. So I really, how should I say, I beseech all of you to commit to doing the best that you can to help our patients live their best lives possible, but for you to do your best work possible in supporting the mission of One Brooklyn and in caring for our community. So thank you all very, very much.
Thank you, Ms. Brown. Dr. Easterling, did you want to make a comment before we started heading to questions?
Good afternoon. Can you hear me?
Yes, I can.
No additional comment. I had the distinct pleasure of joining my colleagues this morning, and certainly I think hearing from our staff, their reactions and additional comments that they may have, I think is really the best use of our time.
Wonderful. Thank you. Okay, so we'll start with our first question. I have Mr. Harold Jones. Will you please unmute yourself?
Yes, good afternoon. My name is Harold Jones. I'm at the cab at Brooklyn, at Brookdale Hospital. I know it's sexy to talk about community, and that's what everybody is talking about, community. But I've noticed Brookdale, and I've noticed that when people talk about community, community means getting a photo op with elected officials. But the thing is that the nonprofits in the community are the ones that are on the ground with people that come to Brookdale. And what I have not seen at Brookdale to this point is where, you get some funds, you got COVID funds, you said, okay, go out and get some people to come and get our COVID or to get our vaccines. And I've done that. I've done 700 people, I think I got the vaccines for. But you haven't interacted with the nonprofit in the various communities to say, how are we going to help Brookdale or get the program in Brookdale to the people in the various communities? That has not been done. And until you do that, people still have the perception that things are not. I have a friend that went to the hospital last week. He went to Kings County. Kings County sent him home and he didn't feel right. So he said he was one that was critical of Brookdale, but he went to Brookdale and he had up 5 days in the hospital and Brookdale solved his problem. And he came back and told me he feels different. And that happens in our community all the time. So until when you get your funds and all that, you have to engage with the people in the community that are working in the ground. If you want your program, you have to engage with them and say, okay, just not send a flyer and say, do this for me. So that's my problem I see with Brookdale and how they interact with the community. I know it's sexy. Everybody wants to talk about community, but I have not seen that engagement.
Thank you very much. Ms. Brown or Dr. Easterling, would you like to comment on his statement?
I'd like to comment, but I'd also like to hear Dr. Scott comment, as she's the executive director of Brookdale. And thank you, Mr. Chair of the Brookdale Community Advisory Board, because what we need to hear where our faults, our warts, and what we need to improve. But what I would say to you is that in addition to our sending out flyers about any new programs or funding that we get, you're absolutely right. We need to call in those community-based organizations. And when we get new funding, talk about how we'd like to use the funding and whether that comports with what they see the need. Now, often, Mr. Chairperson, as an example with COVID, we received COVID monies for very, very specific things. And so there was no flexibility, as it were, to say, well, we'll do ABC. We were provided that funding to do DEFG, and in fact have, we'll have audits as to how we have spent those dollars. But I would also say to you, and I can speak to Interfaith very specifically, we've also provided assistance to, and I'll speak also in terms of Kingsbrook, assistance to community-based organizations where we've actually married them to a funding source for a service that we would and should not necessarily be the providers of, but that service is complementary to and supportive of what our goal is for the service that we're providing to the patients. I'll give you a very concrete example. A group called Health People, which has done a great deal of work with peers, with individuals who themselves have diabetes, and they do training with community residents who have diabetes to become peers and basically health coaches for patients who have diabetes. We actually got funding where we from the Altman Foundation for our Diabetes Center of Excellence. What did we do? We said to the Altman Foundation, we want to take this money and we are going to fund Health People for that $100,000. Not our hiring people, but we're funding them so that we can support this peer health coach, diabetic health coach model that is run by that community organization. I want and support to do more of that, because without our community-based organizations, we can't do a complete job in helping people live their healthiest lives possible, and frankly, in making a difference in terms of the health of the community. That's one example. I'll give you another example. Of the $700 million of capital funding, it's not 1.4 billion, Torian, I wish. It was $700 million of capital funding that One Brooklyn received to make improvements in our facilities, to create a single electronic health record, to literally create additional ambulatory care capacity. We made a commitment to provide more than $200 million of that to federally qualified health centers. Why? Because I said, if the state wants us to improve and expand primary care capacity in Central Brooklyn, we need to envelop the organizations that are providing primary care services in Central Brooklyn to people no matter what their insurance status is. And so I committed those capital dollars to go to those entities. We could have kept it all ourselves, but that's not what we're about. We're about strengthening the community health system, including One Brooklyn, but also our partners. Just to give you two very concrete examples. We can do more, and we will do more.
And Ms. Brown, I'm not the chairman of the group, but what I'm saying is exactly what I mean. is that Brookdale, you have to bring us in and engage us. You have to, I personally have a problem with diabetes. And I know many of my community people, we have to engage and help us to get these people to get education about diabetes, about so many things I want to do. And the problem is we are 501c3, but we have to wait until the city council give us funds. And if we don't have those funds, we don't have it. I see so many nonprofits are dropping out of the system.
So what you should do,
years.
Yeah, to your point about the diabetes though, send me an email and I will link you to Dr. Kodroff, who actually is overseeing our Diabetes Center of Excellence. And if we can, we have the health people peers who are actually running educational classes, providing support to individuals with diabetes, and they go out too. They've gone to, they're not just sitting in an office. They've gone to certain public housing developments and other community-based sites where they will run classes and around what they've learned in managing their diabetes. So send me an email and I will make that connection.
No problem, but you hit the nail on the head. You have to engage us. You have to come in and see what you can do with the nonprofits, how you can help us financially and get the programs going. And that's all.
Right now, Mr. Jones, I'm not going to suggest that we have any money to all, a lot of money. But what I am committed to is that when the opportunity presents itself, and it's a program that we know we need a community-based partner, then we will endeavor to work with that partner and to get them the resources and or share the resources that we get. Like you, we are also, at the mercy of other funding sources like City Council. As you know, we're about to put in, you may know, we're about to put in requests for City Council money on some capital and equipment needs, where we put in some dollars of just last week in terms of some of the discretionary funding. So we're with you in terms of trying to seek funding from all different sources. But oftentimes our proposals are stronger when we are doing it with community-based organizations. Thank you so much, Mr. Jones.
Mr. Jones, Ms. Brown, thank you so much. I want to move on to our next question. Layla Hassan, would you please unmute yourself?
Good afternoon. Are you able to hear me?
Yes.
Yeah. Good afternoon, everyone. I know we talked a lot about the historical and socioeconomic differences that contribute largely to health and racial disparities. We also talked a little bit about mistrust in healthcare based on our patient population, which in my opinion, I'm sure you guys agree, is a public health issue. Given the mistrust and the historical trauma in some cases in history, how do we work to change the perception of our patient population? And how do we work with unconscious and in some cases even conscious biases?
I could.
Dr. Scott is here.
Oh, Dr.
Hi.
Scott is there. Great. Thank you.
Okay.
Yes. Hi, Layla. Well, I would say that one of the most important things is to be willing to have the conversations to name the issues in the way that we did today, right? So once we're transparent and we're able to name the problem, then, or I should say the, kind of the root cause of the disparities, then we can work from the patient care delivery perspective all the way to changing policy. Because in order for us to improve the healthcare of our communities, it's everything from looking at how we deliver care at the front line, all the way to, marching on Albany to help to change the way that our policies contribute to the disparities. And Torian, did you want to add to that?
Yeah. Thanks, Layla, for the question. So yeah, I think you heard today about that spectrum, and certainly on the downstream, on the right side of that spectrum, we're certainly thinking about like the direct care that people receive, and so it's really important that we continue to lift up the way in which care is being properly given, so high quality, excellent care. But we're also wrapping that with, ways in which we're doing patient engagement, ways in which we're, addressing problems that are arising and the concerns that we're hearing and being responsive, right? Because nothing is perfect. And so we're talking about a system that was not always designed to think about, someone's, optimal wellness, optimal health. And so we're talking about care, and there's always going to be some challenges that arise. And so the moment that we know about it, we're being responsive. We are following up with individuals. And, and I want to give a nod to our leadership where we have leadership rounds, really going around to patients, engaging them, talking to their family members, and really thinking about it in a systematic way. Because we need to sort of understand that when those challenges arise, that we're not trying to cover them up, that we're staying on top of them. And then sort of moving to the left side of that spectrum, to the point that Dr. Scott just mentioned, when we talk about understanding how we're going to be addressing that mistrust, well, how are we dismantling the things that are perpetuating and continue to support that mistrust, right? And those are the policies that have already been implemented, that have been decades worth of disinvestment and divestment from the very neighborhoods that have experienced structural racism. Well, how are we partnering, to Mr. Howell's point, partnering with organizations that have been part of this work for decades, ensuring that they are that we're addressing quality of life, quality of housing, safety. And so that is community members, those are community boards, that's our unions, those are elected officials. And that's a strategic way that we can then help message the way in which an anchor system like One Brooklyn Health is doing the work of both downstream, ensuring that care and outcomes are important to us, but then sort of the upstream work of making sure that, really the easiest choice of being healthy can happen, right? And your neighborhoods can really support healthy opportunities. So I think those are the ways that I would sort of frame it, about ways in which we can really sort of address mistrust, not only within the healthcare system, but overall within structures and institutions.
Thank you.
Thank you so much. We have one more question. Ashley Ornstein, please unmute yourself.
My name is Ashley Ornstein. I'm a registered nurse, lactation consultant, and recent family nurse practitioner. And I work at Brookdale. I've been leading the Baby Friendly initiative, and because of that, we were designated Baby Friendly in July of last year. And I just want to say thank you, Dr. Scott, Dr. Easterling, and hello to you, Ms. Lorraine Brown, for your and Dr. Easterling, I just want to talk about your comment on preventative health within the maternal health department. Thank you for that, because we all know that to make the biggest change in health is to help families from the very beginning of life. Having a new start in when you have your new child, or even it initiates like great social health and healthy eating, also benefits of exclusive breastfeeding and connecting with young families. So we need the resources, and we need the resources that will help prevent the morbidities and mortalities that exist within this community. So I'm asking Dr. Easterling, if I'm asking you for your assistance with help in engaging our families more to increase our exclusive breastfeeding rates from 24% last year to 35% this year. And also to continue monitor outpatient results, because some of our families, unfortunately, may not be able to meet their goal inpatient, but be able to meet it outside. And that would include, many of the things that were brought up in this discussion about how we can improve the community. I mean, how can we engage the community and have the community be involved? So I think we should really work together on that. And with that said, if everyone could please in the chat, especially if you work with a community organization, could you email me your community group, or if you have any resources that I can help create a database, so I can share it with our families if they have like a mom or grandmother or auntie that is supporting them with their baby, if they can get the help they need, whether it's in diabetes care, whether it's in mental health. And I would like you all to please email me. I'm going to put my email in the chat. And just again to you, Dr. Easterling, I'm asking for your assistance.
Yeah, well, you absolutely have it, and really looking forward to partnering with you. I'll just say quickly, I think you hit the nail on the head on a couple of the poignant issues, particularly around maternal care, right? Certainly trying to make sure that women of reproductive age are healthy even before they become pregnant, right? And so making sure that we're addressing issues around diabetes or obesity or even cardiovascular issues, because we know that the healthier mom is, we can't throw away that wrapper, right? The piece of candy is the baby, but we have to make sure that the wrapper is just as important as the piece of candy. And so even before the baby is conceived and born, how are we taking care of mom or the parent overall? And so, yes, breastfeeding, safe sleep, quality housing, these are all important issues. And certainly already looking to partner, as I mentioned, Dr. Cyrus McCalla, who is our chair of OBGYN, and his entire team, from Roxanne to Dr. Fracken. So we are certainly thinking together about how we enhance the work that we're doing, again, not just within our system, but then in the community. And some of the organizations that we've already begun engaging on is with Brooklyn Perinatal Network. These relationships are already established, so it's not a new thing. And let me just make sure I'm clear about that. And Caribbean Women's Health Association, because we know what services are necessary, right? We know it's providing safe spaces for breastfeeding or even for breast pumping. We know it's making sure that baby has a safe space for sleeping and that they have all of the education. And so any ways that we can continue to work with you on getting that important information into our community, certainly I'm looking forward to doing that.
Thank you.
Thank you, Dr. Easterling, and thank you, Ashley. Do we have any other questions from the group? Please put your hand up or unmute.
Yeah, I asked the question in the chat. How are we doing on, I know there's a lot of things about minority mothers in childbirth, losing babies. How does Brookdale compare to other hospitals? And number two, Ms. Ray Brown asked me to send her email. I asked for her email address in the chat.
Mr. Jones, can you put your email address in the chat and I'll
Okay.
then respond to you? How's that? A lot easier.
No problem. No problem.
Great. Thank you. And Dr. Scott, do you want to answer his question? And again, I don't have the specific numbers. I can only relate to what Dr. McCalla has said to me, but perhaps Dr. Scott, you can speak to Brookdale's quality metrics.
Sure. So actually, I too don't have the numbers on the top of my head. I do know that about 40% of our mothers deliver premature babies, right? So our NICU is a very busy NICU. And that's one indication that the prenatal care, and Ashley, you might be able to jump in on this as well. They don't have the same quality of prenatal care. And I do know that our mothers have a lot of comorbid illnesses, so like diabetes and hypertension. And those conditions lead to premature delivery. In terms of mortality in our population, I don't have the exact numbers there, but I do know that we have a very complicated deliveries here, and we have a lot of premature babies that are born.
Yes, I can't speak for the data, but I have worked in the neonatal ICU for over several years as a NICU nurse, and I can say that we do amazing work here. We have a wonderful neonatology providers, and we even, if you look at News 12, we had miraculous outcomes. We have a baby that was born very small, and through the great work of the NICU nurses and the neonatologists, that the child was discharged home to the family. So we do really great work here. And, and our families, they are empowered. You know, being a baby-friendly designated facility, we engage with our families and in the best way, keeping them up to date with everything we could provide. And we're working on human donor milk, which is essential for
Healthy baby.
mature babies. So, you know, that's all I can really say in regards to, you know, the NICU for now, but I don't have the data.
Well, what I would say is, in order to be designated as a healthy or baby-friendly hospital, you have to meet certain standards. And Brookdale has met those standards by having gotten that designation. And some of those standards include the numbers of cesareans after the first cesarean, with the idea of the clinical aim of not having, just because you've had one C-section, that you should have another. So delivering moms without a second C-section. Some of them also have to do with percentage of mortalities of the cases that come into the hospital. The point that Ashley just mentioned in terms of the availability of and opportunities for helping moms breastfeed, as well as, you know, human milk. There are all these different expectations or standards of hospitals that, if they're going to be designated as a baby-friendly hospital, they have to meet, and we've met them.
Well, why I asked that question is that my wife worked at Brookdale for 40 years in the mother baby unit, and she's retired now, but I heard her talking to her friends a lot. And what I hear them talk about is that these Black mothers, they run to other hospitals and then to get their care, paternal care, and then they don't go back to these hospitals because they're so far. So when they come, and that's where I think the community has to be involved to get these young mothers to understand paternal care is important. And all my babies were done at Brookdale, all 3 of my kids. But that's why I'm passionate that Brookdale has to engage with the people on the ground. That means the community leaders and not the politicians. They just want a photo op. The nonprofits that work on the ground every day.
Thank you, everyone. Mr. Jones, Ms. Brown, Ashley, thank you all for your assistance. We are going to bring this call to an end. Please join us tomorrow for our closing presentation for Black History Month. And I want to thank you all for everyone who has participated throughout the month in these lunch and learns. We look forward to seeing you again next year. Bye.
Thank you.
Thank you.
Thank you.